Good evening, everyone, and thank you for joining us for tonight's webinar addressing meaningful use functional objectives, focusing on practice and decision support. Tonight we'll go through the objectives that look at the implementation of drug and drug allergy checks, clinical decision support rules, the generation of lists of patients by specific conditions, and the implementation of drug formulary checks. So just as a review, the meaningful use criteria will be implemented over the next few years in 3 separate stages. Right now we're in stage 1 and expecting stage 2 to begin in 2013. Stage 1 really focuses on the the core use of the EHR for quality improvement and data capture for health information exchange. Really focusing on getting those data elements into the system so that they can be reused and repurposed to move data and track care of those patients. Building on that in stage 2 and stage 3, we're going to look at more advanced uses of that data and really getting the greatest value out of the EHR system. Stage 1 is implemented with a series of core objectives, and you must report on all 15 core objectives in order to achieve meaningful use and receive your incentive payment. There is also a menu selection of measures, of which you should select 5 menu measures and report on those 5 with the expectation that the menu measures really will be moved into core in stage 2. So just because you're selecting 5 of those menu measures to report on to be successful for meaningful use, you should definitely consider incorporating the others into your practice as well, looking towards the future. Now, the meaningful use objectives are really divvied into a selection that focuses on capturing that structured data. And again, that data can then be reused to support the practice through the drug checks, drug allergy checks, clinical decision support, etc. Data can also be used then for patient engagement, sending those patient reminders, patient education, and encounter summaries, as well as using that data for care coordination and public health. Really moving those structured data elements around so that we can really track that patient's movement, coordinate care, and make sure the right information is available to all care team members. And underlying all of these objectives, of course, is privacy and security of that patient data. If you've missed any of our previous webinars, feel free to log into our webinar library where you'll be able to access those recorded webinars focusing on each of these functional objectives throughout the series. So our first objective tonight is the implementation of drug and drug allergy checks. Now this is a core measure, meaning that you must meet this measure in order to achieve meaningful use. And this really will be assessed by a simple yes-no attestation. So the measure says that you must implement the drug and drug allergy checks and basically have this functionality turned on for the entire EHR reporting period. Sounds pretty basic, but in a lot of EHR systems, if you don't want to see those alerts, rather than adjusting the alerts to make them more reasonable and appropriate for your practice, a lot of people simply turn off the entire drug and drug allergy check system. So this measure really is working to ensure you don't turn off the system, but you are allowed to make those adjustments and modifications as appropriate to your practice so that you do get the best value for those alerts and reminders. So how does the rule define implementation of drug and drug allergy checks for the purposes of meaningful use? Well, the rule really only considers whether or not the EHR can perform the function and whether it is active. So again, it's really looking to see if you've got the system switched on, or more appropriately, ensuring that you don't switch off the automatic alert system. By default, most EHRs will have this functionality enabled, and again, a lot of times the alerts might be a little sensitive, so you might want to talk to your vendor about going in and really working to modify some of those alerts so that they are more appropriate for your practice. That way you aren't really experiencing that alert fatigue because you have an alert that's consistently giving you a whistle or a pop-up box for something that really is appropriate for treating a rheumatology patient. Modification is absolutely appropriate, just don't switch off the entire system. So certification criteria for meaningful use does ensure that the EHR system is capable of meeting this objective. It really does just look to see that those drug and drug allergy checks are enabled and appropriate for giving notifications, and it does allow you or ensure that you are allowed to make those adjustments to the drug and drug allergy checks. Again, your EHR system will be certified for meaningful use. It's capable of doing both of these functionalities. So just talk to your vendor and understand how your EHR works and how you really can make those adjustments if necessary. So what are your next steps for meeting this objective? First, verify that the alerts really are turned on. By default, your EHR should have these enabled, but it's always good to know and verify that it is turned on. And again, talk to your vendor about how you could modify those if appropriate to best support your practice. You will need to document that the system is on for attestation purposes. Again, CMS has up to 6 years to audit for meaningful use if you do a test and are successful in achieving that incentive payment. So document your report. If you've got screenshots showing the alerts or reminders and can run a report that shows that the system wasn't turned off and that it was enabled through the entire reporting period, print those out, store those in a secure location, double check to make sure the dates are set and cover the entire EHR reporting period. Again, as part of certification criteria, the EHR is verified to report on these measures as well as performing this. So talk to your vendor, know how to run those reports, and how to verify that you do have the system turned on. So just looking ahead, what can we expect for Stage 2 and Stage 3? Again, these are proposed measures at this point. We will be seeing some guidance out of Office of the National Coordinator for Health IT around June 8th, and then do expect to see the proposed Stage 2 rule from CMS in July of this year, at which point we will be reviewing and making comment, submitting that to CMS, and then by the end of this year we'll actually know what the Stage 2 rules are going to be for meaningful use. So in Stage 1, again, simply employing and having that system switched on for drug and drug allergy checks is appropriate to meet meaningful use. For Stage 2, we expect that you will need to employ the checks and the drug allergy checks on appropriate evidence-based interactions. We don't know how that's going to be defined yet, but we are waiting for that rule, and we'll look into what appropriate evidence-based interactions really means in terms of meaningful use. And then you can see that that's even expanded in Stage 3, and again, this is all subject to change, but right now the proposed rules are really looking at expanding beyond just drug and drug allergy checking to drug age checking, drug dose checking, drug lab checking, and drug condition checking. So the important thing here is to, again, learn your system, know how to modify these to make these appropriate for your practice, because we do expect this to be expanded on in the future. So the next measure we're going to review tonight is the implementation of one clinical decision support rule relevant to specialty or high clinical priority with the ability to track compliance to that rule. So again, this measure will be assessed by a simple yes/no attestation. Yes meaning I do have at least one clinical decision support rule implemented in my EHR system. And again, this really is looking to you to decide what is an appropriate clinical decision support rule for your practice. The key here is to talk to your vendor and know how to assign a rule and implement that into your EHR system. So the rule describes clinical decision support as the HIT functionality that builds upon the foundation of the EHR to provide persons involved in care processes with general and person-specific information, intelligently filtered and organized at appropriate times to enhance health and health care. Now, CMS has really provided this definition and then left it up to you. They aren't telling you what clinical decision support rules you need to implement, just that you need to look at your practice and decide what would be a clinical decision support rule of value to help enhance quality care and make sure these patients are getting the right care at the right time. The ACR is looking at our current quality measures and looking into providing some guidance on what you might consider for clinical decision support. related to those measures. And as we move forward looking in Stage 2 and Stage 3, we will monitor the rules and make sure that if there is anything, any more specificity added to this rule, that the ACR will be there to support you and ensure that rheumatology is accounted for. So what you might consider implementing through your EHR may be alerts or reminders or prompts to ensure that patients with RA are on a DMARD if appropriate, or alerts to ensure that patients on a first course biologic do receive a TB test prior to starting that first course biologic. Anything that really makes sense for you and your practice, talk to your vendor, know how to implement that rule, and have that active. Really, the point here is to think through what rule supports your practice and then implement that to enhance care. Now, a certified EHR has been tested and approved to be able to implement these rules based on whatever you decide for your practice. This does go beyond simple pop-up boxes and notifications. Know that you can work with your EHR vendor and identify other features in your system, such as required checkboxes or required descriptive pieces or defined templates, which also would count as clinical decision support. So really, anything in your EHR system that helps you to do the right thing would be considered clinical decision support. So what are your next steps here? Well, identify the rule that you want to implement. Again, for the purposes of Stage 1, only one implementation of one rule is required. So identify something good that you want to work on. And of course, if you want to implement more than one clinical decision support rule, that's up to you. But identifying that one rule and really assessing how it's going to impact your practice and tracking that will definitely help you to build up to expansions in this objective in Stage 2 and Stage 3. And again, CMS does have the right to audit you for up to 6 years after attestation for meaningful use. So I would definitely suggest taking screenshots of the rule and running reports, anything you can to document that you do have this functionality enabled. And again, make sure that that is dated for the entire reporting period and store that into a safe place. You never know if you're going to be up for an audit, and it's always great to be prepared. So looking ahead to Stage 2 and Stage 3, we really see that CMS is focusing in on what they can do to ensure that the clinical decision support rules that are implemented in your system really are evidence-based rules that support quality of care. Again, this is a very vague description, but we do know that they're looking into how they can possibly certify CDS or suggest or recommend or ask for documentation of clinical decision support that is authenticated, credible and evidence-based, patient context sensitive, timely, supports an efficient workflow, integrated with the EHR, and presented to the appropriate party who can take action. And as we see those Stage 2 and Stage 3 rules come out, we'll definitely be reviewing this and again doing everything we can to ensure that rheumatology is supported through this rule and that you do have access to the appropriate resources and references to implement clinical decision support in your EHR that supports rheumatic care. So the next measure to review tonight is the generation of lists of patients by specific conditions to use for quality improvement, reduction of disparities, research, or outreach. So the key here is the generation of patient list. It's really going to be learning how to use your EHR to put in specific criteria to filter those patients and to get a meaningful list that you can then use for really improving care for those patients or outreach. This can really be up to you on how you use that, whether you want to pull a list of patients that are due for labs or patients that might be appropriate for a study of something, or a patient that you want to send reminders to or check in on. It's really up to you. The key is to know how to use your EHR system to generate that list. Now, this is a menu measure, meaning it's one of the 10 optional measures that you must select 5 from. And if you do select this measure, attestation will simply be through a yes/no attestation. All you need to do is to say, yes, I know how to generate a list of patients from my EHR, which can then be used for quality improvement, reduction of disparities, research, or outreach. You don't have to send that list to anyone. You don't have to show evidence of what you did with that list. You simply need to be able to generate a list of patients. And to meet this measure, generation of only one report or list is actually required. Again, the key is to know how to do this, but I would definitely recommend to generate that list and store that in your reporting for future audits. In the case of an audit, you need to support that you did generate this list and that you were a successful, meaningful user. And this list can really be generated on any criteria that you select. Maybe you want to generate a list of RA patients with a certain disease activity measurement, or RA patients that may be due for a certain lab, or all RA patients on a certain medication. Again, any criteria you pick. The rule in CMS really determined that you as the eligible provider is the best person to determine which reports are most useful for your care, and that you are the ones that should be able to select how you direct that criteria and what you do with that report. I would recommend talking to your vendor and learning how to build predefined reports so that you can have a series of those reports stored in your EHR, making outreach and report generation easier in the future rather than having to run an ad hoc report every time you need to use that. The key here, again, really learning to use your EHR in a way that supports that quality of care. So certification criteria supporting this objective. If you do have an EHR that's certified, that means that your electronic health record has been tested and approved that it is able to enable you to electronically select, sort, retrieve, and generate those lists of patients according to the data elements that you define. At minimum, the system has been tested to sort patients based on a problem list, based on medication list, based on demographics, or laboratory test results. Though this is a minimum list, so just because your EHR has been tested against these 4 criteria doesn't mean that's all it's capable of. You might want to, again, talk with your vendor or just play around running lists in your reports and find out how detailed you really can make those reports. Again, getting a list of the most appropriate patients to support that need is definitely the key in gaining the most value of your EHR. It can definitely streamline your workflow when it comes to outreach efforts and make this a much easier and faster process. So next steps here, learn how to use your EHR again. Really learn what criteria you can sort and select from to retrieve that list of patients. For the purposes of this rule, again, you only need to run one list, but knowing that we do expect that this will be used further in Stage 2 and Stage 3 as not only a core measure, but running lists to support specific quality improvement objectives. It's definitely recommended that you look towards those future steps and what you can do with these lists and build those reports now. And again, CMS can ask for documentation of compliance for up to 6 years after you attest and receive funds for meaningful use. So run that report, save a copy, and ensure that you have appropriate documentations that not only is your EHR capable of running these lists, but that you actually did it and can support that yes/no attestation for meaningful use. So again, looking ahead to Stage 2 and Stage 3, we expect that this menu measure will be moved to a core measure in Stage 2. And by Stage 3, ONC is proposing that the patient list be used to manage patients by high priority health condition. Again, we don't have any detail on what that exactly means, and this is definitely subject to change by the time Stage 3 is implemented in 2015. But we do expect that this measure will be a little more specific by then. So focusing on generating those lists and then finding good quality uses for those lists at this time will ensure that you are prepared by the time we get to stage 3. And our last measure to review tonight is the implementation of drug formulary checks. And again, this is a menu measure. So the measure here will rely on a simple yes/no attestation to verify that you do have at least one drug formulary check implemented in your EHR system. Again, the measure states that the drug formulary check system is implemented and that you have access to at least one internal or external drug formulary for the entire reporting period. The CMS doesn't specify what drug formulary. It's really focusing on the functionality to ensure that your EHR is capable of supporting this, this functionality and that you do know how to use and connect to that drug formulary. So how does the rule actually define this? The rule doesn't require that you are able to accommodate every formulary in your implementation. Again, a minimum of one formulary that can be queried, and it doesn't specify what or who to connect to. This really focuses in on what's available to your EHR system and what's appropriate in your area. So this is definitely going to be left up to you to see what's available and what you should connect to. And again, finding the ones that are most relevant for your patients and your practice. So certification criteria, if you do have an EHR that's certified, then the EHR has been tested to ensure that it's able to electronically record, modify, and retrieve steps for implementation of drug formulary checks include the capability to really conduct that automated drug formulary check. You should check with your vendor to ensure that you know what formularies are already connected to your system or how to connect to additional formularies in the future. Again, purposes here in stage 1 really focus on ensuring that your EHR is capable of supporting these functionalities and that you know how to use this and how to expand on it and make it appropriate for your practice. Focus is more on what your EHR is capable of doing and how you use your EHR at stage 1 rather than what's actually what's happening and how many formularies you're connected to. Now keep in mind that CMS can audit you for up to 6 years after submission for attestation of meaningful use. So I would definitely recommend running those reports showing that you are connected to at least one drug formulary, storing that in your audit folder, ensuring that that shows that you are connected to that formulary for the period of the EHR reporting period. So again, 90 days for your first reporting period. And have someone else check off on that. Again, you always want to run those reports, make sure the appropriate dates are set. Your EHR system, again, if it's certified, it has been checked and tested to ensure that it can support running reports and showing compliance with the measure. So if there's any doubts on how to document this, talk to your vendor. They should be able to tell you how to run those reports and ensure that you are appropriately connected to those drug formularies to ensure attestation for meaningful use. So looking ahead to stage 2 criteria. For stage 1, again, implement one drug formulary check, and this is a menu measure. We do expect that this is going to be moved to a core measure for stage 2. And looking ahead, stage 3 proposed rules right now, or proposed guidance, show that they're aiming to ensure that 80% of medication orders are checked against relevant drug formularies. And this is all open and subject to change, but knowing that we are moving forward and looking at more stringent measures in the future, implement this right now with an eye towards that. Not only implement that one, but start thinking ahead to connecting to other relevant drug formularies and understanding how your EHR is working and reporting and how you would add on to that and actually use those drug formularies in the future. So that's all for this evening. Our next Our next webinar will focus in on reporting of clinical quality measures. And as always, if you would like to review any of our previous webinars, access the slide deck, or if you have any questions, please log in to www.rheumatology.org/HIT or email me at hit@rheumatology.org. We'll be happy to work with you in your practice as you focus in on what you need to do to meet meaningful use in the future, and we'd love to answer any questions that you have. Thank you for tuning into our webinar tonight.